Okay, so now we get into the last part of the course, which we're going to go through the diseases by body systems. And the first one we're going to take is the respiratory system. This is a little bit long, plus you had your exam, so you don't have to complete it this week. You do need to complete it next week. Okay. So when we look at these diseases, first of all, we have to look at the respiratory system itself. If you haven't had A&P, this is just very brief. But the function of the respiratory system is that exchange of gases between the atmosphere and the blood. And we're divided into two main parts, the upper respiratory system and the lower respiratory system. And they do have, there's upper respiratory system that has normal flora and the lower really doesn't. So there are some differences between these two areas. So the upper respiratory system is basically bring the air in, get it filtered from contaminants by the nose, deliver it to the lower respiratory organs. So you have the ciliated mucous membrane to trap those particles and those microbes. And there is a lot of blood flow in the nose, as most people know, and that is to warm that air, coming in. You have the pharynx, which is lined with ciliated mucous membranes that push contaminants into the digestive system when you're swallowing. And you have the tonsils, which is a bunch of lymphoid tissue to hopefully detect something coming in. And this is why sometimes when you get a sore throat, it's detected something. And then we have this area is full of mucus, and it does contain antimicrobial chemicals. The lower respiratory system starts at the larynx, right where your vocal cords are. And then below that, you have the trachea and the bronchi and the bronchioles as the branch begin to branch out. And this allows the movement of the air through those lungs. And you end up at the end of the lungs, which are the alveolar sacs. And these are air sacs where the oxygen actually gets exchanged and the carbon dioxide gets exchanged. So there's an exchange back and forth. The diaphragm is very much involved because that is the one that allows you to breathe. Okay, the movement, you have to expand those lungs. That diaphragm has to go down to make space for those lungs and a change in pressure so that that air can get in. And we have all kinds of protective components in mucous membranes. There are macrophages in the alveoli, and there are some secretory antibodies. So if you take a look at it, this is the system, and this is that alveolar sac, and you can see that little macrophage in there. So all kinds of stuff that we have to try and, filter out so that when we actually are exchanging this stuff, exchanging these gases, that there's not too many pathogens in there. So typically, because of all the filtering that's done, microorganisms are not present in the lower respiratory system. There is no normal flora. So if you have something in the lower respiratory system, that's a pathogen, and you've got some kind of issue like pneumonia, you've got some kind of disease. With the upper respiratory system, you have a lot of normal flora. And this normal flora is going to limit the growth of pathogens, hopefully, unless you've knocked them out via an antibiotic or you've taken a chemotherapy drug or something like that. Example of normal flora that we see, Haemophilus influenza can colonize the nose. Staph aureus, even though it's considered the pathogenic staph, is present as normal flora in some individuals without causing disease. Normally you have another staph, but you can get Staph aureus in small amounts, and the normal flora will keep it under control, but some people do carry Staph aureus. Diphtheroids, another one that are colonize nose and nasal cavities, and again, part of this normal flora that we want to see. So these diseases, that may affect the upper respiratory system and the sinuses and the ears and those areas. First of all, we have to talk about strep. Usually get a sore throat. The big one here is Streptococcus pyogenes. And we're going to be going into the groupings of strep. This is one of your labs that is coming up. And it's group A. We type it group A, group B, group C, and so forth. But the group A strep, by definition, is Streptococcus pyogenes. Okay. So it is a beta hemolytic strep. So in that same lab that we have coming up, we talk about the different types of hemolysis. So this will become much more clear to you. But this hemolysis and the beta hemolytic streps are able to take red cells and just burst them open and degrade the hemoglobin within the red blood cell. And so this can get pretty nasty if you don't get it taken care of. It can progress, a strep throat can progress to scarlet fever or rheumatic fever if it's left untreated. So it's, if you've got a really nasty sore throat, make sure that you get it tested to see if you do have strep pyogenes, because you can see all these virulence factors that it has, and it has that hyaluronic acid capsule, so you can't really see it. It has an enzyme that'll break up complement. It's got pyogenic toxins, which produce fevers, all kinds of virulence factors. And so typically occurs when the normal flora gets depleted and you get a large amount of strep being introduced, and then you get the strep throat. This is particularly seen in younger children. If you get them over and over and over again, that's when they generally take the tonsils out, just FYI. But that's what it is. You get that strep throat, and it's high fever and a sore throat and difficulty swallowing, but it could be due to swelling. Those tonsils swell up really nicely. And again, if you see this, that's the time to hit the doc for some antibiotics. Okay, and I'll show you a picture of it in a second. It is spread via respiratory droplets. It usually occurs most often in winter and spring. It is often confused with a viral pharyngitis. So, this is from the throat sore. Is it a virus? Is it strep? Strep usually gets up really nicely with the fever, but sometimes it can be hard to tell, and that's when you need to go to the doc, and they can very easily test to see if it is strep. It's a very quick, fast test, and you're done. And it's fairly easily treated. So here's what it looks like: that redness around the throat, the tonsils, and yeah, it can, if you can get this incubation time is 3 to 5 days. For rheumatic fever, up to 20 days. So you get this red strawberry tongue, headaches, sandpapery rash. You can even get a rash. So these are all the symptoms and everything you may see. But again, rheumatic fever can develop with pain in the joints. You can get all kinds of issues. The beta hemolytic toxin triggers scarlet fever, and you get the rash in the chest. So the main things to look for is, again, susceptibility. It's usually the children that are having the problems with it. The rheumatic fever, 6 to 15 years of age. And again, very easy diagnosis, throat culture, boom, we can do the test and treat the patient, okay? And go from there. But it's nothing to play around with, all right? Diphtheria. This is for people who have not taken the DPT shot. Diphtheria, pertussis, and tetanus. So we're starting to see a little bit more of this because people just really don't want to take their lovely little vaccines. But this is a problem. Before the vaccinations came into play, they were having epidemics of this. And this is nothing to play around with. Diphtheria, basically, the cause is a bacteria called Corynebacterium diphtheriae, and it is virulent. It has a toxin which prevents polypeptide synthesis and causes cell death. The main thing with diphtheria is that you get a sore throat and you get this oozing fluid that hardens into this membrane. And that membrane can obstruct the airways. And this is how most of the people died, because that membrane would get across their airway and they couldn't breathe. Okay. This is a picture of it. You can see it's real slimy, and it hardens up again. It's oozing fluid. It hardens up and it makes it very, very, very difficult for these people to breathe. Diphtheria, the diagnosis is these V-shaped, what we call a palisade arrangements of lined up or V shapes. This is something we can see in a gram stain versus strep, because strep is gram-positive cocci chains. So this looks a lot different, and we can do a fast gram stain if it's suspected. Okay. This is spread person to person versus via respiratory droplets or skin contact, usually these immunocompromised patients, and the diagnosis based on that pseudomembrane. And you can treat with an antitoxin, antibiotics, but the most effective thing is prevention using that lovely little vaccination. Okay, so this is a real good reason why to get the DPT, or if you don't want the pertussis in it, you can get DT, diphtheria and tetanus. But this is one of these that you really don't want to get diphtheria. There have been in the past epidemics of it, and people have really died. Okay. Another one that's more common that we see a lot is sinus problems and ear infections. Okay, sinusitis, otitis media, the middle ear infection. Sinusitis, you got pain and pressure on those sinuses. Ear, it's just severe pain in the ear. You've got pressure against that eardrum, and it just does not feel good. And you can see these different bacteria, Streptococcus pneumoniae. I don't need to take that little, out. I will. Pneumoniae, Staph aureus, Haemophilus influenza, and Moraxella catarrhalis. So there's several different organisms that can cause it. And again, culture it, get it to the lab, and let the lab try and figure out what's causing it. With the sinusitis, most of the time it's an adult. Okay. Bacteria in the pharynx will spread to the sinuses because they are connected via the throat. The sinusitis more common in adults. Middle ear infections more common in the kids. And when you look at this, there's no way to prevent sinusitis. There's no way. The symptoms are often diagnostic. You come in with sinusitis, you're going to feel pressure in these sinuses, and it's going to hurt, and it's pretty diagnostic in terms of that. Basically, again, with the ear infections, the problem with the ear infections and why the kids get those ear infections is the angle of the ear canal. It basically angles down until you grow up as an adult. So anything that gets in the ear has a tendency to get down into it. And so you've got that problem. So just FYI. And so that's why, ear infections in little kids is not unusual. Antibiotics can be used to treat both of these. It may take a little bit longer to treat the sinusitis because that's a hard way for the antibiotics to get to. Otitis, you can put the eardrops in. Sinusitis, you take that the antibiotics, and it may or may not clear up. It may take 2 or 3 courses of antibiotics to clear a good sinus infection, because the antibiotics have a really hard time getting up in those sinuses. Okay. One of the ways that you can help prevent this stuff, it's thundering outside. With the ear infections with the kids, tonsil removal can help, and that will also help with tonsillitis. But a lot of kids, if they get recurrent ear infections, they put the tubes in the ears, and that is to get those ears canals in a better position so that things don't keep getting down in those ears. You don't get that water in the ear and the water stays, and it's a perfect growing environment for those lovely little bacteria. Okay. Another one, common cold, that now we're moving from bacteria into viruses. Okay, so our lovely little common cold. This is the most common human disease, one of the most. I mean, I can't name anybody that hasn't had a cold in their life. It is the primary viral disease of the upper respiratory system. So, yeah, really, really good. The common cause of the cold is rhinoviruses. There are other different organisms that cause it, but rhinovirus is the most common. And most people know the symptoms, the runny nose and the sneezing and congestion and on and on and on. Transmission is through coughing and sneezing and fomites. Okay, person-to-person contact, but you drink from a cup, you wipe your nose, and then you touch a plate or a fork or something or a glass. Anything you touch, you've just put the virus down there. So it's kind of hard to work with in terms of if you've got a family and one person gets the cold, 9 times out of 10, it seems like everybody gets the cold. Okay, and that's why, because it's so easily transmitted. The signs and symptoms are diagnostic. Mainly, you just have to support the patient. There are some over-the-counter medications that help you get through some of the symptoms. Children acquire the colds most often. Children are more susceptible than adults because generally, by the time you get to be the adult, you've been exposed to these viruses enough that you have some immunity. And prevention of this basically is hand antisepsis is important. Just hand washing, disinfection of fomites. If somebody has a cold, really disinfect the dishes and the glassware and that kind of stuff in the bathroom. Do as much as you can. There are some medications that can reduce some of the symptoms, but it's generally, takes you about a week to get through these things. All right, so that's viruses of the upper respiratory system. Now we're going to move into the lower respiratory system. And first, we're going to get into the bacterial diseases of the lower respiratory system. And again, the lower respiratory system bacteria is not usually found there. So when you do get bacteria in the lower respiratory system, life-threatening illness can result. I mean, this is when people start dying from pneumonia and that sort of thing. It's not a lot of times not a good outcome. So their bacteria are not supposed to be there. They get down there, and you're going to have a tough time. So first of all, the bacterial pneumonias. pneumonia is inflammation of the lungs accompanied by your alveoli and your bronchioles being fluid filled. So you don't have good oxygen exchange, good CO2 exchange. There's just not, your gases are not exchanging well at all. We classify them depending upon what's going on. It may be the region that we may classify by. In other words, it's a lobar pneumonia is deep in the lobes. If you can involve the entire lobe of the lung, it can be a lower lobe. We may call it via the bacteria that's causing it. So it all depends on what's going on, what we call it. Bacterial pneumonias are the most serious, and in adults it is the most frequent, particularly our older people. So here's an example of using the name with the organism, and that would be a pneumococcal pneumonia. And that is caused by Streptococcus pneumoniae. And you can see fever, chills, cough, chest pain, shortness of breath. It's just not a fun guy. It has virulence factors. It has capsule that it can adhere and attach to the lung tissue, and it has a lysine that can lyse, so it can dig in there. The infection is usually caused by inhalation of the bacteria, and then the replication of the bacteria within the lung tissue causes the damage. I will say this. This is one of those, the pneumonias particularly, but these can be nasty nosocomial infections that patients get from being in healthcare facilities, particularly the elderly that are laying in bed all the time. It really sets them up for getting some of these pneumonias. The diagnosis is pretty easy if we can get a sputum specimen, and we can culture out the strep pneumo. The treatment drug of choice can be penicillin or one of those derivatives, unless they have a beta-lactam resistant organism. Yes, we do have some. There is a vaccination, pneumococcal vaccine, and it is recommended for the elderly. Being one of the elderly, I have taken my pneumococcal vaccine. Okay. It is one of those things that will help you with the prevention of catching this little nasty guy. Okay. This is what it looks like. It is a diplococci, if you remember, and you can see that lovely little capsule. And right back here. The portal of entry is basically you hail this, and primarily immunocompromised patients, or again, like I was saying, the elderly patients that are just, they're not active, they're not up and around, they're sitting around, they're laying down, and that just sets them up for that. Okay. All right. Atypical pneumonia, primary atypical pneumonia. This is Mycoplasma pneumoniae. These are atypical symptoms: fever, sore throat, excessive sweating. Mycoplasma also has an adhesion protein, allows it to stick to the lovely little tissues. Okay. And you can get it from nasal secretions among individuals in close contact, and they spread that bacteria. The other thing that you get with a Mycoplasma pneumoniae sometimes is a nasty cough. I've seen people with a really nasty cough on this one. Incubation period can be 1 to 4 weeks. The main susceptibility with the Mycoplasma pneumonia, believe it or not, is high school and college students. And we see it more in the younger age, in the teens, early 20s. And it's because you're just coming in such contact with everybody. It's treated with tetracycline and erythromycin. Prevention is difficult because the individuals can be infected despite the lack of symptoms. So it's atypical, and so that you kind of ignore the symptoms. You don't really realize that you're spreading them, or you're going to have a subclinical case, and you've got some problems. This we usually see, like I said, in your college students, your young college students, and your high school students. And this is what it looks like underneath the microscope, electron microscope. Klebsiella. Klebsiella is an interesting one. It gives you a typical pneumonia symptoms with this thick, bloody sputum and chills. Klebsiella, if you ever see it growing on a plate, an agar plate is very mucoid. It does have a capsule. Immunocompromised patients are the ones that are greatest at risk. Incubation phase is only 1 to 3 days. Most of the people coming down with this are going to be hospitalized or immunocompromised in something, or in one of those facilities. Treatment is usually with a cephalosporin and supportive care. And you need aseptic technique with the healthcare workers because it can be easily spread if you're in one of these facilities. So this is something we really don't want spread around because it can get pretty nasty. Other pneumonias, I've got some listed here. The portal of entry is inhalation, also via blood with Yersinia pestis. Yersinia pestis is the organism that causes black plague. You can also get it without developing black plague, but it can kill you in just a few days. So it's not something to play around with. But typically, you will get typical pneumonia symptoms. With Yersinia, you get this frothy, bloody sputum. And it depends on they have different incubation periods. The shortest one is Yersinia, which can produce the symptoms in hours. Typically, the younger children are more susceptible, and we do have some pretty good antibiotics for it. And there is a vaccine for Haemophilus influenza. So one of these things that you might think about getting for your kids. All right, then we go to, I do want to mention Legionella pneumophilia again. In that last lecture again, these are typical pneumonia symptoms, complications with gastrointestinal tract, central nervous system, liver, kidneys. Legionella pneumophilia, it kills the human cells, gets the tissue. This is the one I talked about before with the American Legion veterans in Philadelphia. And this is the one I talked about that I told you need to be careful working around hot water heaters and hot tubs and hot water because this is the one I mentioned that likes it a little warmer. So it does a really good job of sticking around in a hot tub. But just FYI. The elderly smokers, immunocompromised people are at greatest risk. Fluoroquinolones are real good. The best way to do it is just not get it. Make sure that if you've got a hot water heater that you're draining and cleaning it occasionally. Make sure if you've got a spa that you're doing the proper, controls, adjusting the pH, putting, a chlorine in or something like that to keep the bacteria down, and it should be okay. You can treat it with a azithromycin, as I mentioned, fluoroquinolones, and that should be pretty good. We can test for Legionella now. This is a difficult organism to grow, and we had a hard time figuring out what it was because it does require a different agar. And initially, when they tried to culture it out, they couldn't figure out what it was. They could see the bacteria, but they couldn't grow it. It requires a specific amino acid in there. And but we now can test for antibodies to Legionella, so we can get away with that. So here's that lovely charcoal agar for growing that. Okay, a really common one around the world is tuberculosis. This is the leading killer of people that are HIV positive. Tuberculosis around the world is nothing to play around with, okay? It is caused by Mycobacterium tuberculosis, and it can remain viable for long periods in aerosol droplets. So you have to be careful. There are 3 types: primary, secondary, and disseminated. So the first case that you get, you have a minor cough and a mild fever. Those are the initial symptoms. And then later symptoms include sometimes difficulty breathing, chest pain, wheezing, coughing up blood, that sort of thing. When it gets reestablished, it is considered a secondary. And it can then go into multiple body systems, and then it is called disseminated. Immunocompromised patients are most at risk. And again, I talked about especially HIV patients. The way we diagnose it is, of course, our lovely little acid-fast stain and culture. Because these guys have mycolic acid present in the cell wall, and we are able to test for this. There is take a look at, you can see what happens. There is what we call a cord factor that is a toxic glycolipid that's found in these organisms, and it acts as the major virulence factor that enables that bacteria to invade your host, and you form these aggregates. And what happens is these aggregates begin to form, and they drive the granuloma formation and tissue destruction that you get. So basically you get what's called a tubercle forming, and you get necrosis in here, and this is why we call it tuberculosis, okay? And if you get a chest x-ray, you can see it on there. This is the skin test for it, and you can see these tubercles right here in the chest x-ray, okay? The pathogenesis on this, I'll go back, basically, as I mentioned, can remain viable for for long periods of time in drops because of the protection of those mycolic acids in the cell wall, okay? And again, we're going to diagnose with a skin test or a culture. Those kind of things don't distinguish between whether you're a chronic carrier or you have active disease, or those who have been vaccinated, so it makes it kind of hard. The treatment requires a multi-drug regimen versus one. And prevention usually includes vaccination in some countries. And I mean, you need to check if the tuberculosis is really out in those areas and you're traveling, you need to get a vaccination. Okay? This is something you don't want to pick up. Before we started treating and really understanding tuberculosis, this killed a lot of people, and what they did is they recommended they go to a dry climate and they live there. And most of these patients, some of the patients could recover, but a lot of these patients did not. So this has been a tough disease known throughout the history of mankind. Another one is pertussis, whooping cough. This is a vaccine that's in the DPT. It is caused by Bordetella pertussis, and you can see the Bordetella has a lot of various toxins, tracheal cytotoxin, dermonecrotic, so the skin and the getting in there and the nerves. There are 4 phases to this. And what happens is that when you begin this, you get your incubation phase, and then you get the phase where the symptoms resemble a good cold. And then you get a severe cough. And that cough is diagnostic. It's a whooping, I can't even do it, but it's kind of like that. It's a very diagnostic cough, and you can't stop coughing. And then hopefully you convalesce. The treatment is a antibiotic combo. The people that are susceptible are those that have not received the pertussis vaccine. So this is one of those you can, kids used to get this a lot. This is, again, children primarily. And we used to see a lot of it before the pertussis vaccine came out. And so another reason to get your lovely little vaccines, okay? Again, now, it is highly contagious, and it's not fun. Okay, so we're still working our way down here. Diseases are really tough. Inhalation anthrax. This was when we had those scares of anthrax sent through the mail and that sort of thing. Inhalation anthrax can be really deadly. Okay. It is caused by Bacillus anthracis, and symptoms resemble a cold or flu, but progress to severe coughing, shortness of breath, shock, and then death. Not everybody dies, but you get into that where you get short of breath, you don't have really a good chance of making it through. The problem is the anthrax toxin that's secreted by the organism. It is not spread from person to person. You have to come in contact or inhale the endospores. This is an endospore forming organism. It was really interesting. I'm sitting there looking at this, and they're sitting there going, we're using ultraviolet light and running the mail through it. I mean, when we had the anthrax problem, it was like people were getting packages and everything and people were dying if they were opening it up, and so they started irradiating the mail. And I hate to say this, but I'm like, that's a stupid idea. Because as you know, you get anything between the ultraviolet light, it's going to block it. It's not going to do any good. But they were, I guess, trying to appease the people and say, oh, we're doing something. There is the military, there is a vaccine. You can treat this with various antimicrobials if you can get it on board fast enough. There is an anthrax vaccine that military personnel can get, and healthcare workers if they're dealing with anthrax patients or researchers or something like that. So it is. Now, as I mentioned, okay. And then our lovely little viral diseases of the lower respiratory system. Mm-hmm. Number 1, flu. There is no question on this one. Influenza. A lot of you, most of you have had the flu at some point in time. It is full of virulence factors. Viruses, the virus type A and B are the causative agents usually. And I showed you before when we talked about this, there are this enzyme neuraminidase and hemagglutinin. mutate. Those are the things that are responsible for making the different antigens that we see. So the strains are named according to the type, the location, the month, the year, and so it tells us what it is. But usually when we'll go, it's an H1N1 virus. Well, that's what the H and N stand for. It's these mutations in the hemagglutinin and the neuraminidase. Okay. Here's what it looks like. And you can see the neuraminidase and the hemagglutinin on that. And here's the thing. People ask, why do we have to get a flu shot every year? And I've kind of explained this, but I think we need to spend a little time. There's two main processes that the mutations in the virus do. And it's antigenic drift versus antigenic shift. So you sit there and you get drift means you get a little bit of a change. So the influenza virus 1 enters the host cell and it differs slightly, just slightly. So the mutations in those genes occur when that replication within that host cell. And what happens is we will get a lot of times like biennial outbreaks. Okay. You get enough of a difference that you get an outbreak, but it's like it's much more suppressed than it was before. And then what you see is that as that begins to mutate a little more, these cases on the second year begins to come up and come up and come up. You're drifting. And usually what happens with the drifting is that it's small enough that the vaccine that we have works. And so you get the cases of those people that were vaccinated, but the vaccinated ones, it's working. Okay? Where we really have the problems and where we have these outbreaks, these huge outbreaks, is when we get an antigenic shift. And that usually occurs when you get two viruses enter, and influenza virus 1 and influenza virus 2 entered the cell. And then influenza virus 3 varies differently from 1 and 2, so you're getting contact. And what happens is the genes and the antigens from both viruses are incorporated into a new virus that is different, genetically significantly different from the previous years. So you will go along and you go along, you drift, and then all of a sudden you get a shift. Boom. And the cases go way up. Okay. And that's really what happens. And then you'll go back down. You'll have seen this. They'll develop the vaccine for it and everything. And the usual shift, and then boom again. So when you have these tremendous outbreaks, these epidemic pandemics of the flu, this is what happens. You have seen an antigenic shift in those genes on that virus. Okay. Symptoms of flu are produced by the immune response to the virus. The body is trying to fight it and is making you absolutely miserable. I know. Okay. Flu patients are susceptible to secondary bacterial infections because the virally produced damage to the lung tissue. So you can get a secondary bacterial infection. So sometimes the docs, you have the flu and they'll prescribe an antibiotic. That's to help with that secondary bacterial infection. It is transmitted via inhalation of the virus or by self-inoculation. You've touched something and inhaled it. Most of the complications are found, and again, the elderly, the children, and those with the chronic diseases. So here's what it looks like. That's an electron micrograph of influenza. All right. Signs and symptoms during a community-wide outbreak. are often diagnostic, and so you'll know what's going on. And your public health officials will let you know, we've got an outbreak of this, and this is what's coming out, and they'll be testing for it. There are plenty of drugs that will treat influenza if you can get it on board quickly, the Tamiflu and Relenza, and those sort of things. And basically, you can do that and then give supportive care. There, again, there's an there are immunizations with a multivalent vaccine, but again, it's only going to work if it hasn't shifted really hard. If you get a real hard shift, a lot of times that vaccine is not going to work. That is why they look very carefully when they're building the vaccines every year. They do look to China, Southeast Asia, see what's emerging at the time, and see if they can put that in the vaccine, because a lot of times that's where we see them emerging. All right, coronavirus. Yeah, we just went through this. COVID, yeah. This is a large group of viruses that can cause diseases in animals. They often circulate among the camels and cats and bats, and they sometimes evolve and can affect humans. In animals, coronavirus can cause, as I said, diarrhea in the cows and the pigs, and upper respiratory disease in the chickens. In the humans, causes a mild respiratory infection like the common cold, but it can lead to serious illness like pneumonia and can be chronic. The COVID that we got, basically the novel coronavirus SARS-CoV-2 caused COVID-19. This first emerged in China in 2019. It was declared a pandemic by the World Health Organization. These SARS stands for severe acute respiratory syndrome. And what happens is the respiratory droplets enter through the mucous membrane, and you get the fevers, the body aches, and that sort of thing. Typically, incubation of 2 to 7 days. And you want to quarantine these people if possible, because as we found out very quickly, it spreads rapidly. Okay. MERS, which is the Middle East Respiratory Syndrome, was first reported in Saudi Arabia and spread to more than 25 other countries. It originated in camels and emerged to infect people. And about 3 or 4 out of every 10 patients that got MERS died. Now, MERS continued to occur primarily in the Arabian Peninsula, but as of 2019, we've only had 2 confirmed cases. So a lot of the patient that dies, that kind of ends again. There's no, when the patient dies, the virus dies with the patient. Okay? So just FYI, and you can see this. 3 types of the 3 types of coronavirus, MERS and SARS, have the higher fatality rate than COVID-19. You wouldn't think about it considering how many people died from COVID, but they are more difficult to transmit. So that was the problem with the COVID. All 3 originated in animals, although the source, there's some discussion about what the source is, and I'm not going to play the political game there. Most people get infected with the humans that get infected with the human strains. Most of us will get infected, and these illnesses usually last for a short period of time. But when you get a pandemic like what we saw, it gets interesting. But all the patients, supportive care, take pain and fever medications, use a humidifier, take a hot shower, drink plenty of liquids, stay home, rest. And we went through this, going out in public, wear a mask because it is spread by droplets. And so since you have just gone through this, I'm not going to go crazy because most of us have an idea of what COVID can do. And we had millions of cases and we had thousands, tens of thousands of people die. So it can get bad. Okay. RSV. This is an interesting one. Respiratory syncytial virus. This is the most common childhood respiratory disease. Okay. Fever, runny nose, coughing in the babies, mild cold-like symptoms in the older children. At our hospital, we used to get these kids in frequently. And they come in with a fever, runny nose, cough, and the RSV test would come down. Test them for RSV. Okay. Okay. The way this works is this virus causes, and how it gets its name, the formation of syncytia, which can help the virus evade the immune system and infect the new cells. So here's your little RSV coming in. And it basically, you can see this multinucleated syncytium. There's an uninfected cell and they kind of stick together and then it spreads and spreads and spreads and spreads. Okay. Transmission is via close contact. Diagnosis of RSV is by immunoassay. We can also, there's a rapid test for it that we used to use in the hospital. Basically, supportive treatment for children. And again, for the healthcare workers and daycare employees, it's aseptic technique. Keeping it from spreading, and it can spread through daycare and that kind of stuff really, really quickly. All right. The next one we're going to talk about is hantavirus. This one, we've just ended up with an outbreak in a ship. These are rodent-borne viruses that can cause severe life-threatening illness. You typically get this by breathing in airborne particles of rodent urine and droppings, and possibly saliva, but it's mainly the urines and the fecal droppings. And as I mentioned, there was an active international outbreak linked to this cruise ship that involves the Andes virus that has resulted in quite a few deaths. Hantavirus usually is not spread person to person. Hantavirus is endemic in the Four Corners area of the United States. And I always tell people, if you're going there and you're doing any kind of sweeping of old buildings or something like that, wear a mask, okay? Because it is endemic, and there's been some prominent people that have been in the news that have died from hantavirus. So it's not unusual. You basically get a high fever, you headache, body ache, malaise, dry cough, and then pneumonia can develop, okay? The hantavirus pulmonary syndrome is found primarily in North and South America. This condition attacks the lungs and the hearts, and the most common cause in the United States is the cynomolbria virus, which is carried by the deer mouse. This is highly severe and causes, you see that fatality rate of 38 to 50%. There is a hemorrhagic fever with renal syndrome associated with these guys. Is found mainly in Europe and Asia, and this primarily causes internal bleeding and acute kidney damage. Its mortality rate is lower. But I have to tell you, when you sit there and think about this, again, most of the hantavirus cannot be spread between people, but the Andes virus in South America is known to transmit person to person, okay? And that's what happened with the cruise ship. Now, we do have deer mouse in North Carolina, but unlike the Four Corners area of the United States, we've only had like one case in North Carolina. So our mice, our lovely little mice, don't really carry too much hantavirus, or we don't come in contact with it enough. Okay, they're not the field mices; they're the little deer mice. All right, so what happens is the virus is contained in the rodent feces and the rodent urine, and you breathe in that because you're out there cleaning or doing something, and then you start to get the symptoms and you get acute respiratory distress. Okay. All right, so on to fungal infections. Aren't we having fun? Okay, mycoses of the lower respiratory tract, and there are three main ones: coccidioid mycosis. Can I talk today? Blastomycosis and histoplasmosis. Coccidioides. It resembles pneumonia or tuberculosis, and it's primarily found in immunocompromised patients. The pathogen assumes a yeast form at body temperature. And basically what happens is you breathe in what are called arthoconidia that's in the soil, and you disturb the soil and you breathe it in. It is endemic to Southwest United States. I'll show you right here. Here's what it looks like. Yeah, it's pretty nasty. Southwestern United States, northern Mexico, and basically we can get specimens from this and the presence of the sphericals, and we can diagnose these guys. Mild to moderate cases are treated with oral azoles. And if it's severe cases, amphotericin B, which is nasty to take. Protective mask can prevent exposure to these for those in occupations with high risk. So if you're out there in the Southwest and you're doing something like that, working in the soil, wear a mask. Okay. Blastomycosis. This is caused by blastomyces dermatitis. This is a systemic infection. It can produce lesions on the face and the upper body that can get pretty nasty on the face. I will tell you that right now. Or purulent lesions on various organs. The pathogen assumes, again, the yeast form at the human body temperature. The problem with these fungi is they're hard to treat. All the I told you, we have less things to treat these fungi with, so that when we have to pull out amphotericin B, that's really not a good situation. Okay. Here I'm going to show you a picture of it. Basically, the pathogen enters the body through inhaling dust that contain the spores. And again, it's immunocompromised. Most of us can fight it off, but the diagnosis is based on samples of these lesions where we can identify the blastomycosis. There's a first-line antifungal for mild and moderate cases, and it is used as a step-down therapy following initial intravenous treatments. And treatment usually lasts 6 weeks to a year. Amphotericin B is reserved for severe patients, disseminated patients. It is common in relapse in this disease is common in AIDS patients. That's one of those lesions. It's not a pretty thing. Okay, pneumocystis jirovecii. This used to be called pneumocystis canari, but it's changed. Basically, you get difficulty breathing, anemia, hypoxia, fever. You get this from inhaling the droplets containing the fungus. It is very common. It's almost diagnostic for somebody with HIV. The treatment is with several drugs. It's impossible to prevent the infection with pneumocystis because you are already immunocompromised if you have the HIV, and it is not unusual for these individuals to get it. Okay. All right, and that's what it looks like. All right, so you made it through the diseases of the respiratory system. Next up, we're going to do the digestive system.